You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to the new year of 2026 and the January 2026 edition of Editor's Summary. This month, Associate Editor Dr. John Davis interviewed Drs. Sarah Kilder and Annette Vanderhelm van Mil and discussed their paper titled Identifying Resolution of Clinically Suspect Arthralgias, a Step Toward Understanding Spontaneous Reversal of an At-Risk Stage of Rheumatoid Arthritis. This was done on behalf of all the authors of the paper.
Give you opportunity to talk about, for the audience, the key findings of the study. And especially, and I know you'll compare the results between the physician and the patient-based definitions of CSA resolution.
Yeah, so again, we focus on those who did not develop RA and who had sufficient follow-up. So we had 505 patients, out of whom 71% developed CSA resolution according to the rheumatologist. On the other hand, you had 48% who had developed pain resolution according to their outcomes that they reported. So we wanted to study the overlap and discordance between these two groups. And we saw that 158 patients had CSA resolution according to the rheumatologist, but they did not report pain resolution. And the rheumatologist said in these patients that their pain was caused by had a different cause than imminent RA. And the other outcome was that we saw that 32 patients had resolution of pain, so no pain, but the rheumatologist said there's no CSA resolution. And in these patients, we saw that the rheumatologist said that there were still inflammatory symptoms such as morning stiffness. And based on these results, we said that CSA resolution, according to the rheumatologist, had the highest face validity. And that we validated by studying the course of subclinical joint inflammation and functional disabilities over time. And indeed, we saw that both of these outcomes improved over time. And interestingly, patients who had no CSA resolution, according to the rheumatologist, did not show decreasing subclinical joint inflammation, indicating that there may be still an inflammatory process going on. Another interesting thing that we saw was that numerically, patients who had CSA resolution were more often ECPA negative, but we also saw that there was a subgroup of patients who were ECPA positive. More specifically, 34 patients who were ECPA positive did not develop RA at the end of follow-up, and 20 out of these 34 developed CSA resolution. So although these numbers were smaller than the ECPA negative group, we concluded that CSA or reversal of the at-risk stage can happen in both groups. And to conclude my story is also that we saw that at baseline, these patients who would develop CSA resolution later on did not have lower levels of inflammations, but they had lower levels of reported pain, morning stiffness, and fatigue.
I hope you enjoyed listening to part of the interview with Drs. Kilder and Vanderhelm van Mil discussing their paper Identifying Resolution of Clinically Suspect Arthralgia, a Step Toward Understanding Spontaneous Reversal of an At-Risk Stage of Rheumatoid Arthritis. And we'll listen to the full interview as well as the accompanying editorial by Dr. Kevin Dean from the Division of Rheumatology, University of Colorado Anschutz, Aurora, USA. The editorial is titled Understanding the Resolution of Clinically Suspect Arthralgia. Moving forward, but challenges remain. Both the paper and the editorial are available at our website, www.rheumatology.com. www.jrheum.org and on our YouTube channel. Now, moving on to the other articles in the January 26 edition of the Journal of Rheumatology. Next article to discuss is titled Anti-Integrin Alpha V Beta 6 Autoantibodies as a Biomarker of Ulcerative Colitis in Patients with Axial Spondyloarthritis, and is by Yao and colleagues. The investigators found that anti-integrin alpha V beta 6 autoantibodies were present in a significantly higher percentage of patients with axial spondyloarthritis and ulcerative colitis than those with axial spondyloarthritis alone. For the diagnosis of ulcerative colitis among these patients with axial spondyloarthritis, anti-integrin alpha V beta 6 autoantibodies had a sensitivity of 55.6%, but a much higher specificity at 89.6%. When serial samples were examined, 3 out of 10 anti-integrin alpha V beta 6 autoantibody positive patients became negative, but none of the autoantibody patients who were negative became positive. This preliminary study of 18 patients with axial spondyloarthropathy and ulcerative colitis, 29 with axial spondyloarthritis and Crohn's disease, and 48 with axial spondyloarthritis alone suggests that measuring anti-integrin alpha V beta 6 autoantibodies may be helpful in defining the type of inflammatory bowel disease in axial SPA patients and bowel symptoms. There are very promising results with the use of CD19 chimeric antigen receptor, or CAR T cell therapy, in patients with autoimmune diseases and specifically SLE. The next paper by Taubman and colleagues, titled Effects of CD19 CAR T cell therapy on quality of life and direct healthcare costs in systemic lupus erythematosus, a preliminary study, examines other important issues with the use of this therapy. This analysis of 8 patients with SLE who had received CAR T cell therapy and were followed for over 2 years showed that patients had an improvement in their quality of life, with the most notable improvement in physical health. Quality of life values rose to a level which was comparable to a healthy cohort. CAR T cell therapy led to a substantial decrease in annual direct healthcare costs from almost 30,000 euros per year to just over 3,000 euros per year following treatment. We now move on to discuss 2 papers about Sjögren's disease. The first is titled Evaluation of a Practical Approach to Diagnosis of Sjögren's Disease in Clinical Practice, and is by Shaw and Bookman. The authors examined the utility of incorporated the 2016 American College of Rheumatology European Alliance of Associations for Rheumatology Classification Criteria, or the AECC guidelines for Sjögren's disease, into a clinical practice using the weighted score for the classification of greater than equal to 4 of 9. In this cross-sectional study of 374 patients, 70.3% were diagnosed on the basis of Schirmer's test, unstimulated salivary flow, and serological testing alone. 14 were diagnosed after further assessment, which included ocular staining and minor salivary gland biopsy. 16% did not have Sjögren's disease. In an accompanying editorial titled Sjögren's Disease, Does an Accurate Diagnosis Matter?, Dr. Simon Bowman and Benjamin Fisher from the University of Birmingham, United Kingdom, put the paper by Shaw and Bookman in context of the previous literature examining this issue and concluded that the American College of Rheumatology, European Association for Rheumatology classification criteria can be used to diagnose or rule out the diagnosis of Sjögren's disease in clinical practice. Now moving to our next paper by Wang and colleagues, who are looking at a way to score salivary gland hypofunction in patients with Sjögren's disease. Their paper is titled Stratification Approach Based on Salivary Gland Ultrasound for Assessing Secretory Function in Sjögren disease. Using an initial cohort of 164 patients with Sjögren's disease and a subsequent validation cohort of 107 patients with Sjögren's disease, the investigators found that ultrasound scoring system had an excellent discriminatory ability to differentiate between Sjögren's patients with hypofunction and those with normal function. The incidence of salivary gland hypofunction among this total cohort of 271 patients was found to be 18% at the initial stage, 58% in the progressive stage, and as may be expected, 100% in the end stage. In order to determine the prevalence incidence of mortality in systemic sclerosis, and specifically in Western Australia, Host and colleagues studied 877 hospitalized patients with systemic sclerosis over a 28-year period in their paper titled Long-Term Epidemiology of Systemic Sclerosis in Western Australia, a population-level linked data study. The authors found that the burden of systemic sclerosis in Western Australia exceeded previous global estimates. The age-standardized incidence ranged from 0.4 to 3.26 person years, and the point prevalence averaged 37.93 per 100,000 population. Both of these values were higher in females. During the study period, 51.5% died, with a higher mortality rate in males than females. 28.3% died. The standardized mortality rate was 4.17. The main causes of death were solid organ malignancy in 14.4% of the cohort and ischemic heart disease in 10.4%. Barriers to timely diagnosis and specialized care, as well as medication access, are critical for managing all types of rheumatic diseases. Nanda and colleagues examined this issue in patients with vasculitis in their paper titled Navigating the Roadblocks, National Patient and Provider Survey on Barriers to Healthcare and Medication Access for Patients with Vasculitis. Their survey of 100 patients with vasculitis and 31 healthcare professionals found that diagnostic delays were quite common, with 66% of patients reporting an initial misdiagnosis and 36% had consulted 5 or greater doctors before receiving the diagnosis of vasculitis. 57% of the patients waited greater than 1 month for a specialty appointment with a rheumatologist. The major barriers which were reported by healthcare professionals were a lack of family physicians, which 76% of the respondents endorsed, long waiting lists at 58%, and inappropriate referrals in 48% of the respondents. 44% of patients reported challenges associated with medication use, particularly related to adverse effects, out-of-pocket costs, and limited insurance coverage. 93% of the healthcare professionals also reported major medication barriers, which included challenges regarding prior authorizations, step-up protocols, and rituximab access was the most frequently cited medication with a difficult for access. The next paper is by Pongtarak, Kulpanit, and colleagues, and is titled Quantifying Cutaneous Dermatomyositis, a Novel 3D Image-Based Approach. In this study, the investigators showed that the rash area and the redness was detectable in dermatomyositis patients as a significant predictor of the cutaneous dermatomyositis disease area severity index score, or the CDASI score, and that the absolute changes from baseline in the 3D score correlated with the CDASI score. In the text of the article, there are examples of how the rash was studied by 3D imaging and shows that the mapping corresponded to the area and the degree of the rash redness. The authors speculate that in the future, with further refinement of this technique, this could be used in clinical trials or for home monitoring of the rash in dermatomyositis. Juvenile idiopathic arthritis is the focus of the next 2 articles. The first is by Barden and colleague and looks at health-related quality of life in a paper titled Health-Related Quality of Life in Disease-Modifying Antirheumatic Drug-Treated Adults with Juvenile Idiopathic Arthritis compared to Rheumatoid Arthritis and the general population. The authors measured health-related quality of life using the short form 36 score, the SF36 physical component score, SF36 mental component score, and the short form 6D form in 232 adults with JIA, and compared this to 264 rheumatoid arthritis 6 months following the initiation of a DMARD. Patients with JIA had poor physical function but similar mental health scores compared to those with JIA, but both of the cohorts SF36 physical function scores were abnormal when compared to the healthy population, although the SF36 mental component scores were similar in all 3 populations. Similar proportions of JIA and RA patients experienced improvement exceeding the minimal clinical and clinically important difference in the SF36 scores. The SF36 physical component scores, SF36 mental component scores, and the short form 6D scores following the 6 months of treatment. The second paper is titled Juvenile Spondyloarthritis Activity Index Validation in Enthesitis-Related Arthritis and Juvenile Psoriatic Arthritis in a prospective clinical trial setting, and is by Weiss and colleagues on behalf of the Pediatric Rheumatology International Trials Organization, or PRINTO, and the Pediatric Rheumatology Collaborative Study Group, PRCSG, investigators. Using data from a phase 3 placebo-controlled withdrawal study investigating the safety and efficacy of secukinumab in children with ERA and juvenile psoriatic arthritis, the Juniper study, the authors examined the validity of using the Juvenile Arthritis Spondylitis Disease Activity Index, or the J-SPA-DA, in patients with enthesitis-related arthritis and juvenile psoriatic arthritis. They found that at week 12, the mean J-SPA-DA scores showed moderate to good correlation with other accepted measures of disease activity in other JIA subtypes, specifically the J-10 and the CJ-10, as well as the PGA scores. Scores were higher among patients with active as compared to inactive disease. Patients with improved disease activity from weeks 12 to 52 had greater improvements in the J-SPA-DA than patients with worsening disease. The authors concluded that the results of this validation study did show that the Juvenile Spondyloarthritis Disease Activity Index was a good measure of disease activity for children with ERA and juvenile psoriatic arthritis, and this measure can be used in a prospective clinical trial setting. This month, we have a special editorial titled Green Space Exposure, a New Approach for the Prevention and Control of Rheumatoid Arthritis, and is by Drs. Stanhope, Weinstein, and Hill from the University of Adelaide, Australia. This makes for interesting and provocative reading. Our expert review this month is titled Exploring the Genetic Landscape of Psoriatic Arthritis, a narrative review of recent genomic studies, and is by Ellard, Chamard, and Rahman from the Faculté de Médecine des Sciences de la Santé de l'Université de Sherbrooke, Canada, and St. Clair's Mercy Hospital, St. John's, Canada, respectively. This month's article from Rheumatology Around the World is by Rueda and colleagues, and is titled Assessment. This month's article from Rheumatology Around the World is by Rueda and colleagues, and is titled Challenges of Assessment of Spondyloarthritis International Society Criteria in Real-World Colombian Patients with Spondyloarthritis, a cross-sectional study, and describes the JESPA cohort, which is primarily composed of patients with peripheral spondyloarthritis. And the authors suggest that the use of the ASAS criteria in this cohort may lead to misclassification of some patients with clinically diagnosed axial spondyloarthritis. 2 research papers this month. The first is by Udici, Russo, and Poussel, who look at enrollment in trials of ANCA vasculitis in their paper titled Trends in Patient Accrual Rate Screening Failures and Related Reasons in Anti-Neutrophil Antibody Associated Vasculitis Randomized clinical trials. The second is by Mayo Wante and colleagues, is titled Antirheumatic in Systemic Lupus Erythematosus with Severe Hematologic Manifestations, a Spanish multi-center study. There are 2 images in Rheumatology this month. The first is titled Levamisole, Adulterated Cocaine-Induced Vasculitis Mimicking Acute Limb Ischemia. This paper shows the rash and pathology of a 52-year-old man who presented with bilateral lower limb pain, weakness, and a rash, who subsequently admitted to cocaine use. The second is titled Classic Magnetic Imaging Features Unmasked Progressive Multifocal Leukoencephalopathy in rituximab-treated neuropsychiatric systemic lupus erythematosus, and shows serial MRI images of a 42-year-old woman with SLE who had recurrent CNS SLE flares, subsequently received rituximab, responded, but 6 months later again presented with CNS deterioration. The MRI images show characteristics changes of progressive demyelination, characteristic of multifocal leukoencephalopathy. I want to thank you for listening to this podcast and encourage you to read all of the articles in the January 2026 edition of the Journal of Rheumatology. These articles are available in either the print or online edition of the journal. The latter is available at www.jrheum.org. And please watch the interviews of the highlighted article this month and of previous months if you have missed them. They are available for viewing at our website and on our YouTube channel. If you have any comments or questions of any of the articles in the Journal of Rheumatology, please send them to manuscripts@jrheum.com. And please join me for the February 2026 edition of Editor's Summary. And I wish all the readers of the Journal of Rheumatology a happy and good New Year. And I want to thank you for listening.